All right, it looks like we can go ahead and get started. So, hello everyone. Thank you so much for attending today's session. I'm Jacob Goldsmith. I'm the Vice Chair of the Asia Early Career Committee. Today's session is entitled Critical Care, Critical Shortage, the SCI Physician Workforce Dilemma. The scope of today's talk is going to be revolving around the decreasing number of spinal cord injury professionals as it's an increasing problem. And the goal of today's session is to discuss the shortage of SCI physicians entering the workforce, the reasons for the shortage, the role of other specialties, and how we can address the shortage. Today's session is a question and answer format. We have prepared several questions and talking points for the panelists, but please feel free to post any questions you might have in the chat. And if we have adequate time at the end of the session, we'll try to get to those. Today, we're joined by two fantastic moderators. Dr. Michael Fehlings is a professor of neurosurgery and co-director of the spine program at the University of Toronto. He combines an active clinical practice in complex spine surgery with translational clinical and basic science research program in spinal cord injury. And our other moderator for today is Dr. Zach Dymock. He's an assistant professor of physical medicine and rehabilitation at the University of Kentucky. He specializes in spinal cord injury medicine with an expertise in managing complex neurological rehabilitation and advancing evidence-based care. With that said, please take it away, Zach.
Hey, good morning, everyone. I'm going to be introducing the first paper today that is entitled Sustain Our Subspecialty, Addressing the Crisis Within Spinal Cord Injury Medicine. This was co-published by Dr. Camilo Castillo, who is actually my mentor and fellowship director, and Dr. Yelena Svirchev, who joins us today from the University of Washington as well. And that was published in the Journal of PM&R. I'll turn the time over to Dr. Fehlings to introduce the the second paper and authors.
Yeah, thank you so much. So it's a pleasure to be a part of this Asia webinar. So I'm delighted to introduce Dr. Rob Ravinsky, who's an associate professor of orthopedic surgery and a spine surgeon at the Medical University of South Carolina, and will be actually going out west to Northern California to work in the Oakland area in May. And Dr. Ravinsky has quite a distinguished background, but I'm proud to say that he is also a graduate of the University of Toronto and was one of our spine fellows a number of years ago. And it's always a pleasure for me to see people that I've mentored, in turn mentoring others. And so it's a real privilege to introduce Dr. Jason Silvestri, who's a very talented fifth-year orthopedic resident at the Medical University of South Carolina. And the paper that Dr. Silvestri first authored and Dr. Ravinsky senior authored, and I had the privilege to actually be a part of, is entitled Trends in the Supply of Spinal Cord Injury Medicine Physicians in the United States, an Evolving Human Resource Shortfall. And this was actually published in Spinal Cord, and by disclosure, I'm also the editor-in-chief of Spinal Cord, and I had actually chosen this as an editor's choice, and we also did a podcast on this. I think this is such an important area to discuss, and I'm very appreciative also that Asia has facilitated today's webinar discussion.
Thank you.
All right.
Fehlings. That's a wonderful introduction, and I speak for both Jason and myself when I say that we're very grateful to be here. So thank you for having us.
Very good. So I guess over to you, Zach.
Thank you. So without further ado, we'll get into the questions and try to make the most of our time. So this is largely going to be a cattle call format. So each of the panelists are welcome to respond as the question draws their interest and expertise. There are a few questions that we'll try and direct to each of the panelists, and we'll cue you for that. If anybody has questions as we move along, please feel free to chime in. So the first question that we wanted to start off with was, in the multidisciplinary management of spinal cord injury, there is acute care and stabilization, there's initial inpatient rehab, there's long-term follow-up. Which specialty do you feel the shortage of specialized physicians or trainees is most crucial?
Wow, that's a tough one, because the management is multidisciplinary. So I will say that as a spine surgeon, as a neurosurgeon, um, I sometimes find it a challenge to attract surgeons to the care of spinal cord injury, although certainly spine trauma is critical. But the collaboration with our rehabilitation physicians is absolutely critical as well. And so I guess I have an overarching concern that perhaps the whole area of spinal cord injury as a field is maybe not getting as much attention as perhaps it should be. Maybe people are not thinking about this as an area. I know in acute care surgery, it's maybe not always kind of at the top of people's minds. And my sense also from linking with my colleagues in Toronto is that it is becoming more difficult to attract PM&R residents into the specialty of spinal cord injury medicine, which is a big concern to me because, we can operate on the patients, but then, we need to have an excellent rehabilitation, program to maximize the recovery.
Thank you, Dr. Fehlings. I know that one thing that Dr. Castillo emphasized while I was in the training program with him was as much of the team effort and multidisciplinary programming that goes into taking care of patients with spinal cord injuries. And I have found early in practice that unfortunately, as folks come in, there is often a poor understanding amongst our community partners as to how to deal with someone with spinal cord injury and some of those complications. Perhaps we could have each of the panelists comment their own comment. What do you believe drives this physician shortage of interest in pursuing spinal cord injury, either medicine fellowships or being involved in the care of patients with spinal cord injury?
Well,
Dr. Castillo, perhaps we could start with you.
I think the most important thing to understand is that the critical storage of spinal cord injury is, I always make this comment that in acute care rehabilitation, we have a lot of standardized care. And you know this from when you were here, Zach, that after the patient leaves the hospital in my experience, everything falls apart. The long-term community-based SCI follow-up care is extremely fragmented. Acute stabilization is done by surgeons, and we are the department of surgery, by the way. We are PM&R section, but to Dr. Fehlings' point, we have a great relationship because we are embedded with neurosurgery. So early management benefits from specialized centers like ours. The problem is when patients leave our hospitals, and that's what fragmented care start to be very noticeable. And we pretend that these patients with high level of injuries and very complex needs are going to have this amount of paperwork to start dealing with all this navigation, which is a nightmare for even patients who are not disabled. So it is a very complicated issue because that's what the residents and students see us struggling every day. So, but also it's because I don't know, and this is a question that maybe somebody else can answer, the limited exposure for spinal cord injury in other places, because we pride ourselves to have a specialized program, but I don't know how it's in other places. I don't know if there's the same amount of education is for everybody to standardize, because I don't know that answer, sorry. I think exposure to what we do and some measurement is also a problem because our resident students see us struggling, how we struggle to try to do this, but they struggle for much of the overwhelming, but there are places who don't have this. So I don't know what the balance would be. So the geographical aspect of this is very important because Dr. Severson is in Washington University. I'm in Kentucky. This is a very rural area, as you know. So it's a different aspect of that too.
Dr. Svirchev, as Dr. Castillo mentioned, and thank you very much, Dr. Castillo, you practice in a somewhat different geographic region of the country. Could you make any comments about what you feel those barriers are of drawing physicians into the practice of spinal cord injury?
I think that we're fortunate to be in an urban area and working at an academic institution with a very well-established spinal cord injury program. But I'd like to piggyback on what Dr. Castillo said. When we think about what is driving the shortage, the SCI physician shortage, I feel as though it's primarily insufficient exposure to the breadth of spinal cord injury and an insufficient understanding of the career opportunities that are available with spinal cord injury. So like Dr. Castillo said, we're both fortunate in working at academic institutions with strong spinal cord injury representation within our departments of rehabilitation medicine. I suspect that that may not be the case in many physical medicine and rehabilitation programs. And when we look at how our ACGME PM&R program requirements are written, there is very little guideline set to direct how much exposure trainees are to have in spinal cord injury medicine. So if we look at the specific language, spinal cord, the words are mentioned twice, whereas procedures has an entire table of 9 different types of procedures with particular numbers associated with those procedures. And while they say that it doesn't guide competency, when a resident reviews those, or a program director reviews those, or a facility that's looking to open a physical medicine and rehabilitation residency, it is clear that the emphasis is more on the physical medicine aspect of PM&R and less on the rehabilitation. So in theory, a resident could finish their residency program having worked with 1, 5, 10 folks with spinal cord injury and feel as though they are meeting the criteria because that's what's been laid out in the guidelines. And when working with such a limited number of individuals, they may be seeing kind of the most challenging of the folks and not appreciating that our folks with spinal cord injuries do experience catastrophic and really devastating immediate life injuries, but most people are able to work through those times and really see that quality of life remains. And one has to see that spectrum to really appreciate the different aspects and different career opportunities within the field.
Thank you, Dr. Spirchev. I know personally I was benefited from having a very robust spinal cord injury program at my residency, and under the care of Dr. Sarah Salas, who was my mentor during residency and continues to be so, saw that change of I've just had the worst day of my life, and 1 or 2 years later are making incredible gains and being able to do that. I think that was a huge pull for me, and I imagine is so for many trainees. Dr. Silvestri or Dr. Ravinsky, I know that you guys look at this through a little bit more of a surgical lens rather than the PM&R lens. Do you have any comments about what you feel like are those shortages of being able to draw folks into spinal cord injury care fields?
Thank you.
Yeah.
I'm gonna let Dr. Silvestri have the last word, so I'm just gonna jump in really quickly. First of all, I'd like to echo the comments by the other panelists. And I would say that what Dr. Fehlings is seeing in Toronto is something that likewise we see here as well. There is a very big shortage of physicians who are specialists in the long-term management of chronic issues related to spinal cord injury, and it creates tremendous issues with regards to their long-term care. And I think this is a really critically important specialty of PM&R. I would say that to me, I think there are really 3 big bottlenecks in sort of attracting physicians to the subspecialty of spinal cord injury medicine. And I think that they are, as mentioned earlier, a lack of visibility early on in the training pathway, lack of exposure during medical school. I got to be honest, when I was in medical school, I didn't know that this was even a subspecialty. Mind you, that was kind of a while ago, and that was in Canada, and it's a bit culturally different. But I think there's 2 other major issues that I think really are sort of responsible for this shortage, apart from the lack of visibility. And the first is that we've experienced a big cultural shift in medicine in the last 15 or 20 years. And, Professor Fehlings is one of my mentors. I'm sure he's been able to witness this for far longer. And I think that Jason could probably speak to this as well. But there is a move away from seeing medicine as calling, as a noble profession, to something that's a lot more lifestyle oriented. A lot of surgical services have gone from kind of a physician-based to a service-based sort of way of looking at things, where no one surgeon takes full responsibility and full accountability for each of their patients, which I think sort of kind of degrades the level of responsibility. In orthopedics, like I got to tell you, it's brutal for me trying to convince my trainees to consider spine. spine is heavy. They all want to do, sports and hand, and they want to do specialties where they don't have inpatients and they can do procedures that where patients go home the next day where they're healthy, where the medical management is less onerous. And I think that that's probably true in other specialties as well. I think that spinal cord injury medicine, it is a heavy subspecialty. These patients are medically complex. They require very complex long-term care. There's probably a huge amount of emotional and psychological burden for people who are looking after these patients. Zachary said it himself. You're taking care of people on the worst day of their life and trying to get them back to some degree of functionality with very significant physical limitations. So I think that that is becoming more of a difficult sell in the era of wellness and lifestyles. And I just think that we've moved away from, committing yourself to the calling of medicine. And the last is just and I hate to say this, it's a financial thing. It's just that, procedures reimburse more. And in America, people have to pay their student loans, they got to pay their mortgage.
Mhm.
I just think that, we live in a society where finances and money does matter. So it's hard to imagine taking an extra year out of your training to take a job that may not reimburse as much as a procedural job. What do you think, Jason? What are your thoughts on this?
Yeah, certainly. Thanks, Rob, for giving me the sort of the opportunity to collaborate with you on that paper. I think
Well,
to
I
summarize
have
some of
already
the
told the panelists that really this paper was your brainchild, so I want you to
okay,
take full
okay,
credit
fine.
for that.
Well, just to sort of summarize the substance of the podcast that we did with Professor Fehlings for spinal cord, really we were sort of highlighting what the key barriers were, and I think you sort of hit the nail on the head, and it's sort of this shift away from inpatient to the outpatient. And really it's useful to think of the graduate medical education enterprise from an economic lens, right? A supply and demand curve driven by economic incentive. There's no reason or mystery why dermatology is the most competitive specialty for US allopathic seniors, right? It's more pay for less work, right? And so it's a hard prospect to tell a PM&R resident who market value MGMA standard mean of 350 to take another year opportunity cost to, pursue a subspecialty that may ask for more hours for less comp, right? And so that's really what our paper found was over the past sort of decade, we saw a proliferation of fellowship programs, but really the applicants has been really stagnant. And so I think, to address that moving forward, it's really important to sort of expose residents earlier in the PM&R curve to sort of get those who are maybe intellectually curious for this. And, there's still a body of us who pursue medicine for the altruistic purpose, of course. I don't think that that's going to be a huge barrier, but I think the entirety of medicine is facing this shift, right? There's historically the best and the brightest went to finance because that was the biggest sort of bang for the buck. And now it's tech because, our generation and generation X and Y and now Z, they're going to be pursuing sort of the lifestyle. So medical graduates don't want inpatient. They don't want the big loads. They want the procedures. They want the outpatient. And so that's really the big sort of barrier and sort of the answer to the first question that was addressed. The biggest need is going to be in the chronic management of these patients. Orthopedic surgery is another subspecialty that sort of commands some of the highest percentage of US allopathic seniors. And it's, again, just a market-driven phenomenon. And so really that was sort of the point of the paper, was just to try to bring some more spotlight into these areas of medicine that really are sort of struggling to attract human capital.
Thank you so much, panelists, for all of your comments. If I might, one final question before we transition over to the next section to be led by Dr. Michael Fehlings. But there are some thoughts amongst senior PM&R residents that are entering practice who may have some inclination towards spinal cord injury medicine, that they maybe don't need a fellowship in order to be qualified to provide care. And I know that Dr. Svirchev already spoke to sometimes the limited exposure that PM&R residents may receive. Can any of you comment upon the value of a PM&R fellowship and why it would be worth pursuing? Dr. Silvestre, as you answered, maybe possibly without potential financial reimbursement increasing because you are subspecialty trained.
Well, the main thing I want to say is that you're right. One thing I usually tell residents is you have to be, and I think I agree with everything everybody's saying here. One of the main issues is that immediate gratification. A lot of students, residents, they want immediate gratification. Injections get better, surgery get better, procedures get better. In spinal cord injury, is not immediate gratification. For the most part, you really have to be very patient. And you learned your specialty and be good at it by doing exactly that. And you appreciate that. So it's a long journey. It's a long journey. But like Dr. Sherva said, if you're not exposed to that, if you're not exposed to that journey with many, it happens to me with I trained at the VA in Richmond, Virginia, the same thing. You're waiting for a patient to get better, and it's not going to be like that. It's minimal gains for us is huge gains. A toe, a bladder function, a bowel function, that is for us is huge. But you have to have that concept, and that concept in medicine is not taught, right? It's all about immediate gratification. And that's it. The financial piece is extremely important, but also how you feel about your patients and how you feel about getting used to what you're doing and be an expert. It takes time. It's like any other specialty, any other profession. You have to be good at it by continue doing it. And people don't want to wait that long. They want to do it right away. And that's what I love with spinal cord injury, because by being an expert, I can sit down and listen. Sometimes I don't do anything, just listen. But that's the patient knows that he's talking or she's talking to an expert who can actually relieve. And the fact that we work very close with neurosurgeons and neurology is also a huge part of I'm learning from them and they learn from me. So having that exposure to multi-specialty, it helps a lot. So again, if this is great specialty because you learned to be very, very patient.
Thank you, Dr. Castillo. I know for me personally that training as a fellow was invaluable as I have moved into practice, as far as being prepared to
Be
deal
patient.
with those issues. Dr. Fehlings, turn the time over to you for the next section.
Yeah, thank you. So, I enjoyed that, I enjoyed that discussion, kind of on, the sources of the shortage. And I think that we'll kind of segue and perhaps talk a little bit around the concept of teamwork. And I think that this is one of the areas where I think the care of people with a spinal cord injury is actually quite rewarding. And I think for individuals who like to work in teams, this is actually a great opportunity. And that's maybe something that we can emphasize, a bit more, because I think teamwork is something that I see in my own trainees that they really do appreciate. And I think that that's, perhaps something that we could emphasize more. So I might actually start with, with Jason and then with Rob, because, you approached me with the idea of this article, and I was actually really intrigued, why this article? Here you are, you're an orthopedic surgeon in training, you're an associate professor of orthopedics, you do procedures, right? And yet you put a lot of effort into this article, which is really kind of looking at, an emerging shortage of spinal cord injury trained physicians. So why was this important to you? And can you talk a little bit around how these spinal cord injury physicians impact you in terms of, the teamwork that you experience?
Absolutely. So at MUSC, we actually recently started a PM&R residency, and naturally I had some interest early on with medical education, and we really saw sort of like the need, right, of kind of the long-term care of these spinal cord injury patients. A lot of the work that's sort of already been done about early decompression within 24 hours sort of been done, but then afterwards, what do we do with these patients, right? So we saw a lot of these inpatient loads. Oftentimes we'd have 20 or 40 patients with spinal cord injuries at one time. and yet we didn't really have that close collaboration with PM&R. And so that's what we started poking around with Dr. Moni, who's another one of our co-authors on the paper, and Dr. Amit Nagpal, who's one of the PM&R doctors here. And we really wanted to sort of highlight this team-based approach to spinal cord injury. And, I just wanted to sort of offer one thought. I think we're getting to a point where we need to really start thinking about some creative solutions to this dilemma. I think, the opportunity cost behind, an additional year of pursuing spinal cord injury medicine training, I think we could look to other subspecialties that have tried to integrate some of this fellowship training within the PM&R. We did some other work that was published in PM&R in 2022, looking at the variability of PM&R procedures and sort of rotations. And we know that there's certain PM&R programs in the US that offer a robust spinal cord injury curriculum as part of their 3-year sort of residency. And so is there opportunity where we can say there are these subspecialized tracks where you have 6 months early on, and then you finish sort of that 4th year of kind of an intensified spinal cord fellowship training within the residency. So I think we're really sort of at that point where we have to start talking about some of these sort of creative solutions.
Very good. Rob, what are your perspectives?
Yeah, I mean, I think that, all of Jason's thoughts are really spot on, and I think that they're very apropos. I mean, for me, I have a few separate thoughts on this issue. The first is that, as a spine surgeon, I think it's important to come back to your question, Professor Fehlings, why is this important to me and to my practice? And I would say that, I think back to 2 very important sort of events that were in my sort of distant past when I was training and thinking about what kind of doctor I wanted to be. And I sort of became a spine surgeon because I felt like in orthopedics, these were the patients who really needed help, I think that, orthopedic surgery as a specialty is very focused on quality of life, but I felt that the spine patients were the ones who really needed help. But I do remember being a resident and a fellow and thinking that the patients with spinal cord injuries had exceptionally huge challenges, not just for themselves, but also their families and their communities. And I gotta say, and like I think back to being on your service, Dr. Fehlings, and having a very similar discussion in the same vein. And I remember you saying to me very, very explicitly, Robert, it's important to not be too nihilistic about patients with spinal cord injuries. And I was a little bit puzzled about this at first. But then as I sort of became a bit more aware of the role that physiatrists and spinal cord injury medicine specialists play in the long-term care of these patients, it started to click. And what we offer as surgeons is we offer a stabilization, a decompression. These are the tools that we have. And these are good tools, and they're effective tools, but that only takes them to the first sort of obstacle. And then there is a whole host of other medical issues and challenges these patients face that we as surgeons really are not equipped to deal with. We don't have the training, we don't have necessarily the knowledge, the tools, and these fall into the categories of mobility, psychology, muscular contractures, bowel function, bladder function, various different aspects of the psychosocial care of these patients. And yet, as a surgeon, you still feel a huge amount of responsibility for the well-being of these patients. And I think in the absence of having like a very knowledgeable and savvy spinal cord injury medicine team in your institution, you feel very powerless to help these patients beyond their sort of initial presentation. Now, as Jason pointed out, we have a fantastic inpatient PM&R service at our institution, and they've been incredible in helping to coordinate the care of these patients. We do still experience huge bottlenecks due to the shortage, and patients who I think should be going to a specialized spinal cord injury rehab facility have huge barriers and challenges there. But I do see both sides of the coin, what it's like trying to care for these patients in the absence of that chronic long-term specialized care versus when you have a great spinal cord injury trained physiatrist or neurologist
in your institution, it really makes a huge difference for those patients. So I'm very grateful for having these folks around to help collaborate.
Very good. I'm going to shift gears and direct the next question to Dr. Svirchev and to Dr. Castillo. And this kind of relates to medical school trainees. And, often when people are kind of getting into residency, they often already have their career path sort of set, sometimes not. But let's talk about, medical school trainees and what approaches do you think that we can use to inform medical students more about the whole area of spinal cord injury management and, specifically, your areas relating to, the rehabilitation. Helena, maybe yourself first.
Certainly. I will answer the question both from what we as PM&R specialists should be doing and what our colleagues in the surgical specialties could be doing. From the PM&R perspective, we need to be involved very early in medical education. We need to be the ones who are teaching the neuro exam and the musculoskeletal exam and not deferring to our colleagues in other disciplines. I think that there are opportunities for PM&R physicians to be involved in higher levels of medical education. For example, serving on medical school curriculum committees to advocate for inclusion of PM&R and disability visibility into medical student education. And lastly, I think that it's critical for us to really be actively involved in our community. And there are lots of really creative opportunities there. If we are involved in, for example, adaptive sports, that is a wonderful way to attract medical students who are eager to volunteer, eager to participate in exciting activities, to come and see not only a dynamic group of individuals, but then in working with the physicians who are actively involved there, there's going to be some conversation of, hey, what do you do? Well, I'm a spinal cord injury physician, and this is why I'm working this adaptive sports activity, and to start piquing interest very early on. From our surgical colleagues, what I would suggest or what I would ask for is this. I think that many medical schools have little PM&R representation, and in some cases, no PM&R representation. Whereas every medical school is going to have neurosurgical and orthopedic surgery representation, which means that there will be more medical students rotating through your specialties. So introducing the specialty of spinal cord injury to medical students who may not be going into neurosurgery, but are kind of interested in neurology, and there's this deficit, and then bringing up that conversation of, yes, this person has a high-level cervical spinal cord injury. We've done the surgical stabilization. When the surgical stabilization is done, they go to rehabilitation, where there's this whole dynamic team of individuals with specialized skill sets, and collaborate with us in doing that initial recruitment of students very early on in their careers.
Very good. Dr.
I think
Castillo?
I want to add something to. I like 100% agree, wholly agree with Dr. Shervison. I think when trainees see medicine, SCI medicine practiced comprehensively, and that's the issue. Like, we don't know how many programs are strong and not strong, and we don't know the tiers of our spinal cord injury programs nationwide. So when trainees see spinal cord injury medicine practice comprehensive with literature, innovation, research, integration, and like I said, longitudinal relationship, because it's a long-term relationship. If you don't have those patients for a long time, you may not have that exposure. You may not know if you're gonna like it or not. But when you have all those items, the trainees are more likely to go into that part of a specialty. And to the surgeon's point, I think that one of the issues is that we have to be embedded with neurosurgery, neurology, a lot of communication. We go do neuro consult, and sometimes our advice are not follow, and we get really frustrated. This is the reason why we're telling you this. When neurosurgery validates rehab and rehab validates neurosurgery, that's huge, because that moves the patient throughout the continuum. That's what my partner does. She goes to the university and then try to hammer the importance of doing this earlier, Like you said, Dr. Ravinsky, if you don't do this, what is next for these patients? And when there's trainees the people are validating our careers, our field, the trainees say, oh, this is cool. This is what I want to do. And that's one of the issues, but we don't know exactly how we can, how is integrated in United States. We don't know that question, that answer. And that's the main problem.
Great. There's actually a couple of questions that I was just seeing in the Q&A chat, and kind of one related to the issue of physician reimbursement, which was mentioned at the outset, which is an issue. That's a complex issue to tackle. But I'll give you some insight from the Canadian perspective that you may not be aware of, or you may be aware of. But increasingly in Canada, in academic situations, the movement is going away from fee-for-service to what are called alternate financial reimbursement plans, right? And so this separates out where everything's fee-for-service. And of course, that's always going to be very procedurally based, right? To where people are in what's referred to as an alternate financial plan. So where there's a salary, if you will, that's applied, which is independent of the numbers of patients you see or do. And in fact, that's actually becoming quite popular also in academic surgical specialties. So just as kind of an alternative, kind of an approach. But, I don't know what is, what's occurring, in the US around, advocacy there, if anyone, might be able to kind of to shed light, is that something that's, potentially solvable through advocacy? I'll just open this up because I think that was an important question. It's kind of like the elephant in the room.
Yes, it is. Absolutely. As far as private, there's a lot of misperceptions about this. And I mean, the three of us can personally talk about that. Obviously, the limited job availability, that's a misperception. The lower income is also a misperception. Obviously, if you want to, it depends what you want to do and what you feel comfortable. But in reality, there are jobs out there. The VA, Dr. Severson can talk more about that, about the VA specifically. But there are stable academic and VA positions where people can actually thrive. And there's many ways that you can actually work in obviously regional. It's very important what you're going to do, where you're going to work, and quality of life, where you're looking for. The salary question is extremely sensitive because that's very personal and regional and depends on where you work. Between UK, University of Louisville is completely different. I don't know if Dr. Severson can talk about the VA because that's a whole different aspect of salaries and jobs.
There are certainly spinal cord injury opportunities within the VA. As with the VA, there's always been a balance between salary and additional benefits that come with being a federal employee, with longevity and with long-term benefits. And I think I'll leave it at that. With that, I've had a wonderful career as a VA employee, and yes, there are balances that one makes with salary and long-term benefits of remaining within the system, with healthcare benefits and with leave benefits. One piece that I think has been misrepresented or maybe underemphasized within spinal cord injury medicine is that folks do have an opportunity to integrate procedures into their practice. So one can do spasticity procedures, Botox injection, intrathecal baclofen pump management. One can continue doing EMGs on their individuals with spinal cord injury. One can integrate wound debridement. So there are different types of procedures that can be built into a practice in order to make it more procedurally heavy. So this idea that spinal cord injury medicine is a non-procedure discipline, it certainly is not a spine procedure discipline the way our pain colleagues have, but if one is creative, one can really build a robust procedural practice within SCI medicine.
Yeah, so that's a good point, and I think it kind of raises, I think, the importance of, getting this message out. And I this is one of the purposes, of this webinar as well. I just wanted, there's another question or comment really in the chat by Dr. Gorman, and Dr. Gorman emphasizes the importance of other specialties as well in spinal cord injury medicine, and specifically trying to recruit more neurologists. And I can tell you that as a neurosurgeon, very interested in spine and spinal cord injury, I would love to have more neurologists who are really involved in this area. And I can certainly say that in the Canadian ecosystem, we do not have enough neurologists who see this as an area. And I think that's a separate discussion, that's a separate opportunity, but just to acknowledge, that comment. I'm going to kind of switch gears and maybe have another question before I hand over again to Dr. Zach Dymock for the third part. But, I'm quite passionate about the role of research in the training of specialist physicians, and then also in terms of advancing medical practice. This has certainly informed my own professional career. So I'm just going to maybe ask our four panelists to each individually comment, how do we promote and enhance research in spinal cord injury, and what sort of opportunities do we envision that we could try to promote? And maybe Jason, I'll start with you, because you came up with this great idea for this article, but how do we promote research in this area?
Yeah, I think it's really crucial that we sort of support through micro grants. Sort of Asia has these funny opportunities, find a way to, through philanthropy, et cetera, increase research dollars to fund landmark studies, right? We talk about in spine surgery, STASIX, and the importance of early decompression, right? I think in the area of spinal cord injury medicine, there's really a need for outcomes-based research that demonstrates the bottom line ROI to patient-reported outcome measures, satisfaction, life expectancy, et cetera. What is the value proposition to the healthcare system? And so that's really the crux of the matter when it comes down to physician advocacy efforts through Asia, through the American Academy of Neurologic Surgeons, through the American Academy of Orthopedic Surgeons. We need evidence-based research to take to CMS on a yearly basis, right? Because in the US, I know you gave the sort of Canadian perspective. In the US, we're driven by this concept of budget neutrality, where there are the winners and the losers. Historically, the proceduralists have won, but now we're starting to see that CMS is starting to fund EMN visits and primary care and sort of these more medical management. It's starting to reward the cognitive aspect of medicine, and the proceduralists are losing out a little bit. So I think we got to sort of use this momentum a little bit through research to really advocate for more reimbursement for these essential services. And, some of the research we've done in our group has really highlighted that this is really a strain to the system, where over the past 20, 30 years, Medicare reimbursement has decreased 30%, but yet the cost of goods and living keeps increasing. So through research, through physician advocacy, that's how we ultimately advocate for more resources, more funding, and better patient outcomes.
I might actually, okay, Rob, maybe I'll just ask you to comment very briefly, and then I'm just getting conscious of time because I want to hand things over.
Sure, absolutely. And in that vein, trying to stay sort of sensitive to the time, I think that in America, we're very driven by economics. So, based on what we know about preventative medicine and other specialties, if you generalize that to the idea of treating the spinal cord injured patient, preventative medicine is generally more cost efficient than treating a problem. Preventing a problem costs less than treating a problem. And I think that, the whole sort of at the crux of what is spinal cord injury medicine, you're trying to, improve function, you're trying to improve outcomes, but I think that you're trying to prevent things like readmissions, you're trying to prevent decubitus ulcers that get infected and bacteremia. all these potential complications of spinal cord injury. And we also know from a lot of the studies that patients with spinal cord injuries do cost the system a significant amount of money. I think that the key thing that we need to do is I think we need to demonstrate that having physicians who specialize in spinal cord injury medicine saves the system money. It saves resources, and I think that those resources can be reinvested into the physicians and into our healthcare infrastructure. And I think that the way that we figure that out is, is through research. Knowledge is power. And I think that having more financial analyses of the benefits would really be very critical to furthering that cause.
Thank you. I'll hand things back over to Zach for the next portion of our discussion.
Thank you, panelists and Dr. Fehlings for that. In this section, we really want to focus on maybe addressing that shortage as far as getting more trainees into fellowships and getting them out into practice. Obviously, as you guys have commented on, some of the training positions have gone up, but the applicants are not materializing at the same rate. And we're still graduating a relatively low number of spinal cord injury board eligible physicians annually. Could you maybe comment on what do you feel like maybe makes a successful recruitment better in some programs than other, as there tends to be some programs that do fill more routinely than some other programs, and what some of those barriers might be and how we might address some of those barriers? Dr. Castillo, I know that you interact a lot with the fellowship directors. Perhaps that question could maybe be taken by you initially.
I'm gonna give you my side, which is the bad side, and Dr. Severson is gonna be the good side because you always match. So one of the issues, going back to the research question you guys had before, is that the trainees do and sees what we do, right? So one point that I want to emphasize about research, which is part of also recruitment, is time to do research. Institutions need to recognize people because we're very driven to economics, like Dr. Ravinsky said, and we all are driven by RVUs. So we have to produce, and the research it takes time also for research. In institutions, nowadays, academic institutions, they don't want to have the burden of the salary doctor. They don't want to have that. So we have now adventures that private with a university, which is making things much more complicated because one side is economics, the other one is the education, and we have to meet both. And it's becoming extremely difficult to do research and be and also clinicians. And that's one of the things that trainees sees on us, right? Oh my goodness, you're running around like chicken without a head. They don't want that. So having specific time to do research is extremely important. So that's one of the things that I want to emphasize about research. But in general, one thing that I found in my experience having this program for about 7 years is one is experience, having a reputation that you are going to provide the education that you need, even though, as you know, we have all the structures. You have to come here and see it. And people go by why, people know about it. We are very small specialty. Dr. Severson in her article and mine, basically, I thought there were 600 spinal cord doctors out there. There are only 400 board certified spinal cord doctors in the United States. That's even worse than I thought. So we don't have many people in training, and we don't have many people that are teaching this. So we don't have enough strong spinal cord physicians teaching spinal cord injury, and a lot of people are getting taught by generalists. So it's not bad, but we have to figure out how they teach it. So that's one of the reasons. One of the problems I see. And then patient volume, like you mentioned, there are programs who maybe have 4 or 5 patients. I can tell my experience when I trained at the VA, I had 1 patient on a ventilator for the entire year. There were not many, but I learned a lot from that patient. And after I left, your career continues to grow. So there are many things you have to see as a trainee and as a doctor, how you're going to practice in the future. And I think that's one of the issues that people want a structure at the beginning. They want already the structure. I told you when you came here, you have to help me to build the program. You tell me what I do right, and you tell me what I do wrong, because we were the baby ones trying to figure it out, and we did. But people have to believe in that. You have to believe that we have the structure, and you also have to also deliver that structure, deliver the education, and you have to compromise. Again, like I said, if you have the leadership, the initiative, the research, you have everything in place, you can deliver. People have to come, and that is the issue. How do you help them to come to a place like this? Dr. Servison?
I think reflecting back on the question of what has made our program successful in recruiting fellows, not always successful. Last year was a dismal year for fellowship applicants.
For everybody.
Where it was a rough year.
Yeah.
We have the benefit of offering a very diverse training experience for our fellows. So being able to appreciate spinal cord injury from different flavors. The VA SCI population is different than the acute trauma population, is different than the pediatric population, is different than the medically complex, unusual disorders or spinal cord injury as a result of other disorders, has been invaluable, and I use that to my advantage. Things I wonder other SCI fellowship programs may consider is more aggressively partnering with local healthcare facilities or other healthcare providers to build that diversity into their programs. It may be a change in culture to some of their programs. I wonder if there are some rehabilitation programs or SCI fellowship programs who have historically said, we don't see metastatic tumors. We don't do spinal cord tumors. Cancer rehab is not part of our practice. There's a tremendous potential in working with folks with those diagnoses. Similarly, cervical myelopathies. I think that oftentimes traumatic spinal cord injury is what's considered spinal cord injury, and our folks with very incomplete injuries may not be receiving the inpatient services they need. So there are different ways that that diversity of experience can be introduced into SCI fellowships that I think that our fellowship programs should more aggressively pursue. The other piece that I think that fellowship programs may need to use to their advantage a little bit more is the flexibility of training. So when we look at the guidelines within ACGME criteria for SCI fellowships, they're pretty loose. 3 months of inpatient, 3 months of outpatient, you can do anything else you want with the other 6 months. So using that as a selling point to our fellowship applicants to say, hey, what are you really interested in? And if the person says, I want to do some research, is there a way that you can really integrate that into their practice? Or if they say, I really want to do procedures, great, let's find a way that we can focus on integrating spinal cord injury focused procedures into your practice. Those are a few ideas that I can share.
Thank you, Dr. Spirchev. And you touched on one of the questions that I wanted to cover in this section of the panel, which was if you have a residency program and they do not have a strong spinal cord injury exposure, what can be done to help gain some of that exposure? And you noted community partnerships, maybe broadening the scope of patients that you are seeing across various settings, including inpatient or outpatient, making sure to include cancers and cervical myelopathies and other things that still cause spinal cord injury, but maybe not in the traumatic sense of a motor vehicle accident or a fall. I appreciate that. Is there any other comments from the panelists on other things that you think that training programs could do in order to provide more exposure, both depth and breadth for spinal cord injury?
Well, I think in my case, it's concentration of longitudinal care for these patients, and as you know, the exposure of having nurses, navigators, and other options that are not out there, it helps to enhance the breadth of the program and to really train people what reality is and what's going to happen and what you're going to face in the future. That's something that I always had believed strongly, which is access for these patients when they need it.
To be honest, I still call your nurse navigator for help, and I'm graduated. For those that don't know, Dr. Castillo has a fabulous nurse navigator that is a true asset in this field. I'll turn the time back over to Dr. Fehlings here as we're getting close to the end of our program.
Well, this has been a wonderful a webinar which has dealt with critical care, critical shortage, the spinal cord injury physician, workforce dilemma. And, we've had a very, interactive discussion involving, a team of spinal cord injury rehabilitation physicians, a mid-career orthopedic spine surgeon, a senior neurosurgeon, and an emerging orthopedic specialist. We've had neurologists commenting in the question field. And I just want to commend the American Spinal Injury Association Asia for having this committee, which is really focused on physicians who are kind of early in their career and on this topic. And I think this is really a nice collaboration also between Asia and the International Spinal Cord Society, who in some regards I'm representing as editor-in-chief of Spinal Cord. But, we've talked about, the importance of teamwork in the management of people with spinal cord injury, the collaboration between surgical specialties and rehabilitation, and that this is really critical. And, the outcomes of surgery are better, and more patients are emerging into rehabilitation facilities who are incomplete. And this really allows for, a much greater application of the techniques and technologies of rehabilitation, and also trying to reintegrate individuals into society and enhancing the quality of life, of individuals. So there's tremendous value to this. And, from the economic perspective, from the health system, the prevention of long-term complications that can arise in individuals with spinal cord injury is quite critically, important. And we've talked about the emphasis of increasing the awareness in medical schools to medical students and exposing residents in training, to the value of this, but also advocating with healthcare funders, around the importance of this. And, I think that organizations such as Asia, can play a tremendous role in terms of doing this. And I think on that note, I think I'm going to hand things back over to Dr. Jacob Goldsmith. And Jacob, I'd like to also thank you for your tremendous work behind the scenes in terms of organizing, this. You put a huge amount of work into this, which is all behind the scenes, but I want to thank you as well. And I want to thank my co-moderator as well, Dr. Dymock. It's been a pleasure, doing this session with you as well.
Thank you so much for the kind words, Dr. Fehlings. A huge thank you to our amazing panelists and the moderators today. I think this is a fantastic discussion. Thank you to everyone who attended the session as well, and thank you for participating and submitting questions. I just want to take time to say that the topic of our upcoming early career webinar series is going to be non-traditional research designs that we can leverage in SCI research. And so please stay tuned for additional details on that about the upcoming webinar series. And just thank you again, everyone. Really appreciate it. This is a fantastic discussion. Thank you.
Thank you very much. That's
Thank
wonderful.
Thank you all.
Bye, everyone.
Bye-bye. Bye-bye. Thank you.